In continuing with acid-base balance, the lungs and the kidneys play important roles in the extracellular fluid pH hemostasis. The interrelationship of the lungs and kidneys in maintaining the pH is shown by the Henderson-Hasselbalch equation, which is as follows: the pH equals the pK plus the log of A minus over HA. A minus represents the proton acceptor or the base, which in this case it can be bicarbonate, and HA represents the proton donor or the weak acid, which represents carbonic acid. It's the weak acid. pKa is the pH at which there is an equal concentration of the protonated and the unprotonated species, as I said to you before. So knowing any of these variables, any of these three variables will allow for the calculation of the fourth variable here. Okay, so next thing is in terms of what goes on with the lungs and the kidneys. So carbon dioxide, as I said before, will diffuse out of the tissue into the plasma and red blood cells in the capillaries. In the plasma, a small amount of carbon dioxide is physically dissolved or combined with amino groups of proteins to form carbamino compounds. Most of the carbon dioxide, though, freely diffuses into the red cells and is catalyzed by the carbonic anhydrase enzyme, which combines it with water, right? And it does that to form H2CO3, which is carbonic acid. And that then will dissociate into hydrogen ions and bicarbonate. Okay, so again, that is the typical reaction of what goes on with CO2. The dissociation of carbonic acid causes the development of a concentration gradient in the system due to an increase of bicarbonate concentration. So because there is an increase in bicarbonate, there is a change in the concentration gradient. Bicarbonate ions then diffuse from the cells and diffuse into the plasma. So to maintain electron neutrality, chloride then comes in and diffuses into the cells. And this is what is called the chloride shift. So you have this right here. To maintain electron neutrality, in terms of the concentration of carbonic acid and bicarbonate, chloride will diffuse into the cells. And it usually does it at the same time as bicarbonate travels in the opposite direction. Okay, so that's the chloride shift. So hydrogen ions are generated by binding with recently deoxygenated hemoglobin molecules. HHB is deoxygenated hemoglobin. So it is a hemoglobin molecule that is bound to hydrogen instead of oxygen. In the lungs, the ventilation affects the pH of the blood. So oxygen is inspired and then it diffuses from the alveoli into the blood, and that forms oxyhemoglobin or oxygenated hemoglobin. And then CO2 diffuses into the alveoli from the blood and it is eliminated via ventilation, right? So when you breathe out, it is eliminated. This will result in a minimal change in hydrogen concentration between the venous and arterial circulations. So when the lungs do not happen to remove carbon dioxide at the rate that it is producing carbon dioxide, it will accumulate in the blood and it would lead to increased hydrogen concentration levels. If, however, CO2 removal is faster than its production, right? When there is hyperventilation, CO2 removal, right? So it's like you're breathing out CO2. Then hydrogen concentration will be decreased and the pH of the blood will be increased. So changes in hydrogen concentration of blood that come from basically non-respiratory disturbances cause the respiratory center to respond by altering the rate of ventilation in efforts to restore the blood to normal pH levels. Okay, so again, let me repeat that. Changes in hydrogen concentration of the blood that come from non-respiratory disturbances cause the respiratory center, the lungs, to respond, right, to these changes by altering the rate of ventilation in efforts to restore the blood pH to normal. So the lungs and the buffer systems, again, so the first line of defense um, uh, that will respond to these acid-base changes that are occurring in the body. So this is basically a picture from your book that shows you the interrelationship of bicarbonate and hemoglobin buffering systems, bicarbonate and hemoglobin. Okay, so in the kidneys, so what happens in the kidneys is that the kidneys regulate acid-base balance by excreting acids or bases, okay? And they play a very, very important role in these acid-base conditions. So the main role of the kidneys is to reabsorb bicarbonate, okay? To reabsorb bicarbonate. So bicarbonate is basically reclaimed from the glomerular filtrate in the kidneys to prevent excessive acid gain in the blood. Remember, it's a weak acid. From the loss of bicarbonate in the urine. If bicarbonate ions were not reabsorbed and excreted in the urine, this would impact the bicarbonate carbonic acid buffer system, which would then cause an increase in hydrogen ions. So it's doing it to regulate the hydrogen ions. In a healthy person, almost all of the filtered bicarbonate ions is reabsorbed. But when a patient is experiencing alkalosis, the kidney excretes bicarbonate ions to compensate for the elevated blood pH levels. So the lungs basically participate in regulating the blood pH through hypoventilation or hyperventilation. And the kidneys are the non-respiratory component. That's also known as the metabolic component. And what they do is they, again, like I said in the last slide, they control the bicarbonate concentration in the body. Oh, sorry, I didn't mean to move on. So pH imbalances can occur due to conditions or diseases that affect either the patient's breathing, which could affect the lungs, and that would be the respiratory component, or that can affect kidney function. Again, kidney function is the metabolic component, which is also the non-respiratory component. In assessing the acid-base hemostasis, the components of the bicarbonate buffering system are measured and calculated, right? So we're talking about the dissolved CO2 or the DCO2, and which is in equilibrium with CO2 gas, which can be expelled by the lungs. And bicarbonate carbonic acid system is also called an open system because the CO2 can be removed. The DCO2, the dissolved CO2, is expelled. That is expelled by the lungs is part of the respiratory component of this system. So in the plasma, and at 37C, the pKa of the bicarbonate carbonic acid buffer system is 6.1. The concentration of carbonic acid is proportional to the partial pressure of excreted dissolved CO2. The value for the combination of the solubility constant for PCO2 and the factor to convert milliliters of mercury to millimoles per liter is 0.0307. The solubility constant is dependent on the temperature and solvent, pH, and the partial CO2 are measured in blood gas analysis, as I said to you before. So the pKa is a constant, right? Bicarbonate can be calculated in when you have the pKa. So the reaction would be as follows. The calculation would be as follows. pH will equal the pKa, which is a constant, plus the log of bicarbonate over 0.0307 times partial CO2. So remember, the value for the combination of the solubility constant for PCO2, partial CO2, and the factor to convert milliliters of mercury to millimoles per liter is 0.0307. Okay, so when the kidneys and lungs are basically functioning properly, the ratio of bicarbonate to carbonic acid should be 20:1. And that would correspond to a normal pH, a pH of 7.4. The bicarbonate levels, or measurements denote the kidney function, which is usually the numerator of the reaction, and partial CO2 represents carbonic acid, and that denotes the function of the lungs, which would be a part of the denominator in your calculation. The lungs will impact pH through retention or elimination of CO2 by ventilation, as I said to you before, and the kidneys will regulate pH by excreting acid, primarily in the ammonium ion, and by reclaiming bicarbonate ions from the glomerular filtrate. And these here are some are part of the calculations that and reference ranges that you'll be working on. But this is an example. The pH, normal pH is between 7.35 and 7.45. You have a bicarbonate level of 24 millimoles per liter, partial CO2 of 40 milliliters of mercury, and so the bicarbonate over the dissolved CO2 should give you a 20:1 ratio. So these are the calculations to determine the dissolved CO2, the total CO2, the reactions, the CO2 reactions when it combines with water to yield carbonic acid and dissociate into hydrogen and bicarbonate, and the regular calculation, which is the pH equals to 6.1 plus the log of bicarbonate over dissolved CO2. So bicarbonate is always the numerator, and then dissolved CO2 is the denominator. All right, so when you probably already know this, but when there is an increase in pH, you have alkalosis. When there's a decrease in pH, you have acidosis. If bicarbonate is increased, the numerator gets increased and the pH gets increased, which means there is alkalosis, right? If CO2 is increased, the denominator gets increased, which means the pH is decreased, which would yield to acidosis, right? So whenever the pH is decreased, there's acid. Whenever the pH is increased, there is alkalosis. So you do have to remember these relationships. All right, so acid-base, just remember, osis refers to a process in which the process that is occurring in the body, and emia refers to the corresponding state in the blood, right? Emia. So acid-base disorders result from imbalances in the acid-base equilibrium, obviously. When the blood pH is less than the reference range, it is termed acidemia, or when there's an excess of acid or hydrogen ions. And this will result in hydrogen ion concentration that increases through increased partial CO2, or decrease in the bicarbonate concentration. When the body pH is greater than the reference range, the condition is called alkalemia or excess base. And this will result in hydrogen ion concentrations that are decreased, either from decreased partial CO2 or increased concentrations of bicarbonate. So now we can start talking about the particular disorders that have to do with acid-base imbalances. A primary respiratory acidosis or alkalosis. This is a disorder that is caused by ventilation dysfunction. So basically a change in partial CO2, which is the respiratory component. It affects the respiratory component, right? So respiratory acidosis or alkalosis, a disorder that is caused by a ventilatory dysfunction, right? So it has to do with partial CO2 in the respiratory component. So you can see that there can be non-respiratory acidosis, which is a disorder that results from a change in the bicarbonate level, a renal or metabolic function. In other words, it is a decrease in bicarbonate resulting in decreased pH. And when there is compensation, that means that there's a response in the body to maintain acid-base hemostasis. It is accomplished by altering the factor that is not associated with the primary process. So it is accomplished by altering the factor that is not associated with the primary process. So mixed acid-base disorders can arise from the presence of more than one process or compensatory mechanism in response to the primary disorder. For example, if the imbalance is of metabolic or non-respiratory origin, the body compensates by altering ventilation. On the other hand, for disturbances in the respiratory component, the kidney will compensate by selectively excreting and reabsorbing specific ions. The lungs will immediately compensate by retaining or expelling CO2, which is a short response. And the kidneys are slower to respond. It usually takes about 2 to 4 days, but it is a long-term response and it is a sustained response. So there could be full compensation or partial compensation. In full compensation, the pH has returned to normal range, and in partial, the pH is approaching normal ranges. So the amount of acid that exceeds the capacity of buffer system, and there is a decrease in bicarbonate to less than 24 millimoles per liter, means that there is metabolic acidosis. So in metabolic acidosis, again, remember, acidosis can occur either through a metabolic issue or respiratory imbalance, okay? So this is in particular metabolic acidosis. So this is when the amount of acid capacity of the buffer system and when there is a decrease, when the amount of acid exceeds the capacity of the buffer system, and when there is a decrease in bicarbonate to less than 24 millimoles per liter. A decrease in pH here is due to the decreased ratio of metabolic to respiratory component in the Henderson-Hasselbalch equation. The body then compensates for metabolic acidosis by hyperventilation, so blowing off CO2. And this can be caused by acid-producing substances or the production of organic acid in diabetic ketoacidosis. It can also be produced by the reduction excretion of acids as seen in renal tubular acidosis and due to excessive loss of bicarbonate from diarrhea or from drainage from a biliary, pancreatic, or intestinal fistula. So this is metabolic acidosis, which is one of the acid-base imbalances, or one of the disorders that have to do with acid-base imbalances. All right, so metabolic acidosis uh, some of the symptoms are it affects the central nervous system. So there's central nervous system depression, confusion. The patient can experience a coma. There is lack of energy, sleepiness, breathing rapidly, nausea, and flushed skin. And in the lab results, you would see a decreased bicarbonate, an increased pH. If the condition is compensated, you will see a decreased partial CO2, and the compensated pH should be between 7.35 to 7.40. The next condition in acid-base imbalances is the respiratory acidosis. So as I said to you before, acidosis can be metabolic or respiratory depending on what's being affected. So in here, there's a decrease in alveolar ventilation. So there is hypoventilation causing decreased elimination of CO2 by the lungs, right? So this respiration is regulated by the medulla of the brain. It can be caused by ineffective removal of CO2 from the blood, maybe through some sort of lung disease. It can also be caused by COPD, which is airway obstruction, and this causes changes in air spaces due to the reduction of the lung surface area. In COPD, the CO2 is retained in the blood, causing chronic hypercarbia, which is elevated levels of partial CO2. Respiratory acidosis can also be caused by drugs such as barbiturates, morphine, or alcohol, by decreased cardiac output or congestive heart failure. Um, and compensation of this condition occurs through the metabolic system. However, it takes hours to days to affect the pH. Remember, the metabolic response through the kidneys takes about 2 to 4 days. The kidneys will respond by increasing the excretion of hydrogen and reclaiming bicarbonate. When bicarbonate increases, it'll cause the pH to return to normal. So, respiratory acidosis causes slow to difficult breathing, headache, drowsiness, confusion, decreased levels of consciousness, muscle twitching, which can also lead to convulsions, palpitations. In the lab results for respiratory acidosis, you'll see a decreased pH, because of acidosis, an increased PCO2 because remember we don't have the ability to release the CO2. You'll have a decreased oxygen. If it is compensated by the kidneys, you'll see an increase in bicarbonate ions, and compensated pH would be between 7.35 to 7.0. The next condition is the metabolic alkalosis. Metabolic alkalosis, it'll be an increase in the pH. However, it has to do with the metabolic component, which are the kidneys. So in here, there is a gain in bicarbonate that causes an increase in pH in the system. It can be caused by excess administration of sodium bicarbonate or through the ingestion of bicarbonate-producing salts. Excessive loss of acid through vomiting, nasogastric suctioning, or prolonged use of diuretics that also increases renal excretion of hydrogen ions can also cause metabolic alkalosis. Hypokalemia and chloride deficit also stimulate the reabsorption of bicarbonate in the distal tubules. And compensation would occur when hydrogen ions sensors in the brain signal respiratory center to slow down respiration, which will then result in hypoventilation, which will then increase the retention of CO2, which will increase partial CO2 and lower the pH in the system. And here, the primary cause of metabolic alkalosis has to be corrected first. Some of the symptoms associated with metabolic alkalosis are shallow breathing, irritability, twitching, confusion, and picking at bedclothes. Also, rapid heartbeats. The lab result will give you elevated levels of bicarbonate, an elevated pH, excuse me, increase base excess on arterial blood gas testing, and the compensated pH would be 7.4 to 7.5. The next condition is your respiratory alkalosis, which is an increase in alveolar ventilation, causing excessive elimination of CO2 by the lungs. So that can be caused by hypoxemia or hysteria-induced hyperventilation, by chemical stimulation of the respiratory center by drugs, pulmonary emboli or pulmonary fibrosis, in which the oxygen exchange is impaired. And compensation will occur through the kidneys by excreting bicarbonate in the urine and reclaiming hydrogen ions. The symptoms for respiratory alkalosis are headache, vertigo, agitation, tingling or numbness around the mouth and fingers, and tightness, which is a ringing in the ears. The lab will show you decreased levels of partial CO2, increased pH. However, if there is compensation of respiratory alkalosis, you'll see a decrease bicarbonate level and a compensated pH between 7.4 and 7.45. Okay, so remember, oxygen in metabolism is crucial to life. Partial CO2 is measured basically to evaluate the patient's oxygen status, and is typically measured along with pH in your routine blood gas analysis. So oxygen and carbon dioxide are measured together, and basically there are 7 conditions that are necessary for tissue oxygenation. So there has to be available atmospheric oxygen, adequate ventilation, the gas exchange between the lungs and arterial blood has to be adequate, loading of oxygen onto hemoglobin has to be perfect, there has to be adequate hemoglobin concentrations, adequate transport of the oxygen, and also adequate release of oxygen to the tissue. So basically, if there are any disturbances in these conditions, it can result in hypoxia, which means there is poor tissue oxygenation. So tissue oxygenation is very important, and oxygen and carbon dioxide are measured together in blood gas analysis. So the amount of oxygen that's available in the air depends on the barometric pressure, the VP altitude. At sea level, the VP is 760 millimeters of mercury. The percentage for each gas is the same in all altitudes. So partial pressure for each gas is equal to the BP, the barometric pressure, at a particular altitude times the percentage for each gas. So some of the common factors that influence the amount of oxygen that moves through the alveoli into blood and then to the tissue are the destruction of alveoli, pulmonary edema, airway blockage, inadequate blood supply, and diffusion of carbon dioxide and oxygen. So here are some factors that influence the amount of oxygen to the tissue and some more common causes of inadequate perfusion. Perfusion is the passage of blood, basically the way the blood is flowing, right? So inadequate blood supply can occur, and that can be due to a pulmonary embolism, as I said before, a pulmonary hypertension or heart failure. Diffusion of CO2 and oxygen can also cause those imbalances in oxygen, and intrapulmonary shunting, which is non-functional alveoli that prevents venous blood from being oxygenated, which results in decreased oxygen content. Also anemia. When there is anemia, there's less oxygen present. So again, the transport of oxygen is very important. Most oxygen in the arterial blood is transported to the tissue by the hemoglobin. Hemoglobin A, as you already know, can bind 4 molecules of oxygen, and the amount of oxygen that gets loaded onto that hemoglobin really depends on the availability of oxygen concentration and the type of hemoglobin. It also depends on competing molecules, pH, temperature of the blood, and partial CO2 and the 2,3-diphosphoglycerate, which is 2,3-DPG. When all of these conditions are normal, more than 95% of functional hemoglobin will bind to oxygen. So blood hemoglobin exists in one of four conditions, right? It exists as oxyhemoglobin O2HB, which is oxygen that reversibly gets bound to hemoglobin. So oxyhemoglobin is oxygen that is reversibly bound. And deoxyhemoglobin is the hemoglobin that is bound to oxygen but is capable of forming a bond with oxygen when it is available, that is not bound to oxygen. It is also known as reduced hemoglobin. Carboxyhemoglobin, COHB, is the hemoglobin that's bound, and methemohemoglobin is the hemoglobin that's unable to bind to oxygen because of the iron molecule. That is in an oxidized state rather than the reduced state. So the quantities that are associated with assessing the patient's results or patient oxygen are the oxygen saturation, the fractional oxyhemoglobin, and the transient oxygen saturation and oxygen content. The oxygen saturation is the ratio of oxygen that is the ratio of oxygen bound to a carrier protein, which is the hemoglobin, and that is compared to the total amount of hemoglobin capable of binding oxygen. The fractional oxyhemoglobin is the ratio of the concentration of oxyhemoglobin to concentration of the total hemoglobin. And trends in oxygen saturation are assessed by transcutaneous pulse oximetry. And the oxygen content is measured by getting the total oxygen in blood, the sum of the oxygen bound to hemoglobin, and the amount of dissolved oxygen in plasma. The hemoglobin and oxygen dissociation curve shows you that oxygen has to be released at tissues from its carrier, which is hemoglobin. Hemoglobin, again, has four molecules, heme molecules, that transport the hydrogen and carbon dioxide from the tissue to the lungs. Oxygen dissociates from adult hemoglobin, which is hemoglobin A, in a characteristic fashion, which is an S-shaped curve fashion. The partial oxygen is graphed on the x-axis and the percent saturation of oxygen on the y-axis. The shape of this oxygen dissociation curve and the affinity of hemoglobin for oxygen can be affected by the hydrogen ion activity, the partial CO2 or CO levels, the body temperature, and 2,3-DPG. The position of the oxygen dissociation curve reflects the affinity of the hemoglobin to oxygen that reflects the rate of dissociation. And here you see that here you see A, B, and C. Curve B is the normal human curve. Curve A is blood with increased affinity, and C, blood from decreased affinity. So in oxidative metabolism, it increases in temperature, hydrogen, CO2, and 2,3-DPG, and that results in a right shift of this curve. This decreased affinity of hemoglobin, it's decreased affinity of hemoglobin to oxygen, which facilitates oxygen uptake for the tissues. Here, what you're seeing again is curve A, B, and C. B is the normal curve for oxygen affinity. A is the curve from blood with increased affinity, and C with decreased affinity. So in the lungs, the temperature, hydrogen, partial CO2, and 2,3-DPG decrease relative to the tissue levels, shifting the oxygen association curve slightly to the left, which is A. And this enhances oxygen binding to hemoglobin to improve oxygen uptake. There's determination of oxygen saturation can be done by spectrophotometric methods. The actual percent oxyhemoglobin can be determined using the CO oximeter that is designed to measure various hemoglobin species. Each species has a characteristic absorbance curve. The number of wavelengths incorporated into the instrument determines the number of species that can be measured, from 4 to hundreds. Here are the most common hemoglobin species, which is hemoglobin, hydrogenated, the oxygenated hemoglobin, oxygenated hemoglobin, COHB, and methemohemoglobin. There are potential sources of error with this type of methodology, which can be in faulty instrument calibration and spectral interfering substances. Here is the graph for the different types of hemoglobins that can be measured using the optical absorption of hemoglobin. So the measurement of blood gas analysis, pH, PCO2, and partial oxygen can be done in these blood gas analysis with pH, PCO2, and PO electrodes. There can be amperometric or potentiometric measurements. Amperometric measures the current flow that indicates oxygen present in the blood. And the potentiometric measures a change in voltage, which indicates the analyte activity. So it measures CO2 and pH. The cathode and the anode are also used in the measurement of these blood gases. So the first is the negative electrode, and also it is the site to which the cations tend to travel. It is a site in which reduction occurs. In the anode, it is the positive electrode. It is the site to which the anions tend to travel and the site in which the oxidation occurs. The electrochemical cell is formed when two opposite electrodes are immersed in a liquid substance that will conduct the current. So the measurement of PO2, of partial O2, can be done with PO2 electrodes, which measure the amount of current flow in circuit, and it's related to the total amount of oxygen. With this method, there can be some sources of error in which there can be buildup of protein material on the surface of membrane, bacterial contamination within the measuring chamber, as well. This method does continuous measurements of partial oxygen, and these are done possibly by using the transcutaneous electrodes that are placed directly on the skin. Also, there is measurement of the pH and partial CO2. There's an ion force measurement that requires 2 electrodes and a voltmeter, and the potential difference is related to the concentration of ion of interest by the Nernst equation. There are 2 types of electrochemical sensors, the macroelectrode sensor and the microelectrodes. The macro are used in blood gas instruments since the beginning of clinical measurements of blood gases, and the micro are the miniaturized macroelectrodes. There are thick and thin film technologies as well, and these are sensors that are tiny wires embedded in printed circuit card that are disposable. You can also use optical sensors, and these use fluorescent dyes into which the sample diffuses, and they have been applied into indwelling blood gas systems as well. Calibration of the systems of the instruments in blood gas measurement is very, very important. These pH and blood gas measurements are very sensitive to temperature. The electrode sample chamber must be maintained at a constant temperature. The pH electrode is calibrated with two buffer solutions. You can use a traceable to standards that is prepared by the National Institute of Standards and Technology. Their two gas mixtures are used to calibrate PCO2 and partial O2. Most instruments are self-calibrated and they get programmed to indicate that there is a calibration error if there is some sort of electronic signal from the electrode that is inconsistent with the program expected value. So also in blood gas analysis, it's very important to consider pre-analytical issues as well. So there's important to identify the patient correctly, to label correctly, and an experienced person who is knowledgeable in doing this testing should be drawing and testing for these blood gases. Proper collection is very, very important, and handling of the blood specimens is also just as important. It is also very important to follow the CLSI procedures for the collection of arterial blood specimens. Specimen collection for blood gases has to be done for arterial blood. So that's what's drawn, and you use a glass or plastic syringe. Heparin is the anticoagulant of choice. You will flush the syringe with sodium heparin and then empty the syringe. Right after that, you will try to expel the air bubbles. You will remove the needle, cap the syringe, transport in ice, and evaluate. Very important to do this, to evaluate within 15 minutes. It's also very important to mix carefully by rolling the blood in the syringe between your palms. You uncap and you run immediately, and also you check for clots, making sure that there are no clots. This is an example of a syringe that you would use to draw arterial blood for blood gas analysis. So it is important to make sure that there is no delay in the analysis. Eye samples maintain values for 1 hour, but non-eye samples quickly become invalid. So CO2 would increase, O2 would decrease, and pH would decrease. So you want to avoid that. Large air bubbles that are not expelled also increases the oxygen levels, and delays in running the specimen after uncapping will increase oxygen, decrease carbon dioxide, and increase the pH. So these are issues that you need to be careful with when you are analyzing blood gases. Hyperventilation due to anxiety will also I'll give you different results: unmixed specimens, clotted specimens, technical errors, and temperature. Again, blood gas measurements are very, very sensitive to temperatures. The higher the temperature of the blood, the greater the change in blood gases that you will see. So quality control, QC, procedures are performed routinely when doing blood gases, and this will assess the process in the three components of the analytical phase. So obviously QC requires assessing pre-analytical, analytical, and post-analyticals. For QCs, we use surrogate liquid control materials, which are the basis of most of the traditional lab QC practices, right? So usually for blood gases, these are sold in sealed glass containers with solutions that are equilibrated with gases for known concentrations. You will run QC in duplicate assays, and also it's important to participate in external interlaboratory surveys, or proficiency testing programs to make sure that you're running these tests correctly, and also that the results are valid for gas measurements. And this is just a diagram of blood gas analysis, a QA cycle, showing the importance of quality assurance when measuring blood gases in the laboratory. You'd have to include all the the pre-analytical, analytical, and post-analytical variables. And that ends your lecture on blood gases. There's part A and part B of blood gases, so please continue on to your review questions that are posted in Moodle. Thank you.